Now for today's panel and fireside chat. It is now my pleasure to introduce today's general session on slow violence, health inequity, and the future well-being of communities. First, Dr. Mindy Thompson Fullilove. She is a board-certified psychiatrist who is interested in the links between the environment and mental health. She started her research career in 1986 with a focus on the AIDS epidemic and became aware of the close link between AIDS and place of residence. Under the rubric of the psychology of place, Dr. Fullilove began to examine the mental health effects of such environmental processes as violence, rebuilding, segregation, urban renewal, and mismanaged toxins. She has published numerous articles and 6 books, including Urban Alchemy, Restoring Joy in America's Sorted Out Cities, Root Shock, How Tearing Up City Neighborhoods Hurts America and What We Can Do About It, and House of Joshua, Meditations on Family and Place. I'm especially honored to have Mindy join us today, not only because of her expertise, but because she has had a personal hand in my professional development as a public health leader. Nurturing my talents and intellectual curiosities first as a preceptor in 1988, then on my thesis committee in 1990, and as a trusted mentor every step along the way. So I am where I am in part because she is who she is. So please welcome Dr. Mindy Fullilove.
Hi, everybody. I just want to say there are a group of wonderful people that moved to the front row, so thank you. All right. I want to talk about inequality in cities. The point that I want to make here is that inequality is not static. It's a process, and it's a process that's growing worse. And therefore, it's not simply a problem of maldistribution of resources. And so we have to have both process interventions and resource redistribution interventions. And so that's what we're up against. I just want to say that in today's New York Times, there were 2 articles that I found shocking. It's sort of about both of these problems, kind of just to say the issues that are going on. The first was the growing loneliness of being black in San Francisco. Apparently there aren't going to be any black people left in San Francisco, except for Danny Glover. But if you meet him, if you're black and you meet him walking down the street, you can smile at each other and feel at home. Meanwhile, the New York Times had a special section on cities, and what this section highlighted was really technology, the sort of idea that, well, we'll have smart cities and that'll solve all the problems. So obviously the smart solutions will be concentrated in some cities like Burlington, Vermont, and not at all in other cities. I was learning about Pasadena, Texas in an earlier session today, and certainly the poor neighborhoods in Pasadena won't have much technology. So we have both these process problems. There used to be black people in San Francisco, and there aren't going to be any more black people in San Francisco. They're going to get pushed out, and we also have these maldistribution problems. So how are we to think about this? The thing is that part of the change has been our constant struggle against inequality. So over the past few years, and I think these are things that we in public health have contributed to and we know about, certainly rights of the gay, lesbian, bisexual, and transgender populations have gained tractions. Huge, huge, huge shift. Jim Crow principles have lost traction. I think that's true even in spite of seeming evidence before us of rising racism. I think in general the principles have really been rejected by our nation. And of course the problem that the rich people took almost all the money, which is just a stunning problem and part of this issue of maldistribution and what do we do about it. I think these 3 issues have been in front of us. I think we've been articulate on these issues. I think we have contributed to the debate and contributed to the resolution. But the third process problem, the third shift, is one where I think we don't understand it, and yet it is really horrific. And this helps us to understand why there aren't going to be any black people in San Francisco. And that is that there's a process that my research group has called serial forced displacement that has wreaked havoc on neighborhoods. This process is a very long-standing one, certainly builds on segregation that was established in the Jim Crow era, but continues with redlining, continues with urban renewal, planned shrinkage, the foreclosure crisis, and now gentrification. So what are these processes doing? These processes are picking selected neighborhoods, Black neighborhoods, Hispanic neighborhoods, other neighborhoods of poor people, and pushing the people out. Each of these policies does it in a slightly different way. Urban renewal is very different from gentrification, but the end result is the same, which is that a neighborhood that was a community of people of color is no longer. So the classic examples that are on everybody's mind are Harlem as an African-American community. It will no longer be an African-American community, and the Mission District, which was a Hispanic community, will no longer be a Hispanic community. It's this change, this transformation. When we say communities lack something like food deserts, and the solution is to get better grocery stores into a community, that's a good idea if the communities weren't being pushed out of that place. And therefore, it is not enough to say we have to redistribute the resources. In a city, we also have to stabilize the places where people are going to live. And why do we have to do this? Because what really makes people healthy is community. And when we talk about community, we're talking about generations of people living in systems of equity and exchange together and getting along, learning how to solve their problems. So that's what public health is really got to embrace, because that is what I believe we are really about. I believe that, a simple way to put this is that we are trapped in the redlining paradigm. Redlining was set up by our federal government in the 1930s, and it basically stratified cities into 4 parts. At the top were white neighborhoods that had new housing and restrictive covenants, so undesirable racial elements could not move in. At the bottom were the neighborhoods with the most undesirable racial elements, which were Blacks, Hispanics, Jews, foreigners, a whole lot of people, and old housing. What it said to the banks was, don't invest in those poor neighborhoods. So it really set up this whole system of maldistribution, or anchored it in federal policy. The policies, to some extent, have been eliminated, but the paradigm is still with us. So at my group, we believe that people's struggles to change structure must continue, but we need new tools. In the 1990s, when we were studying the crack epidemic and we became aware of the vast amounts of trauma that were affecting people in recovery from substance abuse, we said we had to have trauma-informed care. But now what we say, because we think we succeeded on that, is that we also have to have urbanism-informed care. And so I wrote a book based on what I learned from going to many cities and seeing people who I thought were at the cutting edge of helping to fight these battles. And out of that, I developed a periodic table of the elements of urban restoration. The goal of this is largely to say, we have to have an understanding of the urban ecosystem and work in that frame. It has been very exciting to go to communities and talk to people about this. We had the great opportunity to work with a group called Spirit House in Durham, North Carolina, which convened a citywide reading of urban alchemy. At the same time, there was a wonderful article in the alternative paper about the American Tobacco Trail. And does it divide or unite Durham? And so we said to the reading groups all around the city, go see the city, read that article, go look, see how your city is divided by race and class, and think about what you want for the future. And this was fabulously exciting. These are some of the leaders of Spirit House going to walk the American Tobacco Trail, and some of the maps that were done by Kofi Boone, a local landscape architect, to help, which were part of the article and helped inform the reading groups, and people gathering to study and review what they had learned. But most importantly, people went to parts of their city they hadn't seen before, and they found things that inspired them. And I just want to say that they found stuff that in other neighborhoods that people loved. And this is what Michel Cantal-Dupart, a renowned French urbanist, have called elephants. Elephants are fabulous things. So we got invited to go to Niagara Falls to teach them about urban alchemy. And this is the city of Niagara Falls. This is Main Street on a Saturday afternoon, completely deserted. And what is so shocking is that The falls are one of the 7 wonders of the world. The difference between the kind of collapse and disinvestment in the city and this magnificent wonder and the ways in which they are literally, physically separated from each other is just astounding. How is that to be repaired? So we took them on a walk to find the elephants in their city. And this is a community center, been closed for years, but they said, we love this place. We want it to reopen. This is one of the elephants in our city. And with chalk, they filled in this stencil of elephants, and then they wrote something fabulous. They wrote, "Love lives here." And I have been saying to myself, you know, in a city that's suffered from this kind of disinvestment, where it's half emptied out, but it's fabulous, the people are great, how do you lift up this Niagara Falls to the level of the magnificence of the 7th wonder of the world? And as a psychiatrist, I want to say that when people can say love lives here, they have matched Niagara Falls for splendor. And one of the things that we teach people is make a mark. So they took that thing that they had discovered and they made a bumper sticker with an elephant, and they said, "Love lives here," and they're putting that on people's cars. We can get to know our cities in this new way. We can understand these dynamic ecosystems. We can become the people who fight for community, to be stable, to be loving, to be fabulous, to be interconnected, to be all the things that human beings need in order to have population health. Thank you.
Great. Thank you, Mindy. Now I would like to introduce Dr. Donald Warne. He is the chair of the Department of Public Health at North Dakota State University, and he serves as a senior policy advisor to the Great Plains Tribal Chairman's Health Board. In addition, he is an adjunct clinical professor at the Arizona State University Sandra Day O'Connor College of Law, where he taught American Indian health policy. Dr. Warne is a member of the Oglala Lakota tribe from Pine Ridge, South Dakota, and comes from a long line of traditional healers and medicine men. He received his MD from Stanford University in 1995 and his Master's of Public Health from Harvard University as a Commonwealth Fund Harvard University Fellow in Minority Health Policy in 2002. Dr. Warne is a certified diabetes educator. He is a diplomat of both the American Board of Family Practice and the American Board of Medical Acupuncture. In addition to minority health policy, he has completed a fellowship in alternative medicine from the Arizona Center for Health and Medicine. Now, unfortunately, due to weather and related flight delays, Dr. Warne is unable to join us here in person. However, we are able to connect him through the magic of Skype.
I can't hear you. Can you hear me?
We can. We're going to just turn the volume down a tweak, and we'll be good to go. Please go ahead.
Okay, can you hear me okay? All right, I assume you can hear me. Yeah, and I apologize that I can't be there in person. Yeah, as was mentioned, we unfortunately had some travel challenges, so I wasn't able to attend in person, but I'm very happy and honored to be a part of this important discussion, and I really appreciate the topic, focusing on health equity and also looking at how health equity and inequity can occur over many decades. And this certainly is true for the American Indian population. I'm going to go to the next slide. I always like to start these discussions with a traditional American Indian story. And in the old ways, we would tell stories to really understand how the world works and learn our lessons through stories. And there's a story of 3 sisters walking along a river. And as they're walking along the river, they see babies and small children in the water struggling to stay afloat. And the first sister jumps in and said, "This is a crisis. We need to get these babies out of here right away." The second sister jumps in and says, "No, we need to teach them how to swim so they can survive while they're in the water." And the third sister just keeps walking upstream. And the other 2 said, "Where are you going? Why aren't you helping us?" And she said, "I'm going to find out who's putting these babies in the water, and I'm going to stop them." So that's public health. from a traditional Lakota perspective, working further upstream to try to understand what are the basis of some of our challenges. Next slide, please. So I'm originally from a small town called Kyle, South Dakota, on the Pine Ridge Indian Reservation. And it's a very small community. And we unfortunately suffer from a great deal of poverty, but my community is very rich culturally and in terms of our history and cultural connectedness within Kyle, South Dakota. On the next slide, you can see our school. It's called Little Wound School. And this is K through 12. On the far left is kindergarten, on the far right is high school. One of our big challenges is that less than half of the kids who start kindergarten actually finish high school. So our dropout rates are just a little bit over 50%. And that's not unusual for many of our reservation communities. And the challenge then becomes, who will be our leaders in the future? Who will be the healthcare professionals, the educators, the business leaders, et cetera? On the next slide, you'll see the cafe that's located in Kyle called the Food Stop. And this is a food desert. There's very limited options for healthy food in my hometown. And I think what they've learned here at this particular cafe is that you can bread and deep fry just about anything and serve it for lunch. And when we think about the foods that are in this area, it's things that can be stored for long periods of time, things that can be put in a freezer and then thrown into a deep fryer. And that's essentially what we have access to. The other reason I like this picture, it's an action shot. You can see the res dog chasing the little girl down the street in front of the cafe there. On the next slide, right across the street from the cafe is the gas station. And the gas station doubles as a grocery store. So people are dependent on the gas station if they want local access to food. And as you can imagine, it's mainly processed foods that can be stored on a shelf for long periods of time. There's a small section for fruits and vegetables, but unfortunately they are much more expensive than you would typically find in a city or in a suburb, because it costs money to transport the fruits and vegetables to this community. So any perishable item is actually more expensive. So we face all kinds of challenges in terms of being a food desert, and over many decades, we see terrible health outcomes as a result. Next slide, please. This is actually a picture of one of my uncles, and you can see he has an amputation. And unfortunately, because of high rates of diabetes, less access to healthy food, less access to good health services, we have terribly high rates of type 2 diabetes and its complications. So in my community, there is a program in which they will build a ramp for people who are in a wheelchair. So that's wonderful that we'll build a ramp when people are disabled and need to use a wheelchair so they can get into their home. However, wouldn't it make more sense if we invested in healthy food in the first place? So it's remarkable to me, really across the entire country, we're acting like that first sister jumping in the water and treating everything as it is a crisis, rather than working further upstream and really trying to make an impact on prevention. So when I look at the outcomes now, the health challenges we face are largely preventable, and we have a lot to learn, I think, from our traditional perspectives on health promotion and population health. On the next slide, this is a map of the Indian Health Service areas. And it's important to keep in mind that there's not a single American Indian culture. There are hundreds of tribes, hundreds of languages, and a lot of differences culturally across the United States when we look at American Indian populations. Unfortunately, where I'm from in the Great Plains, we tend to have the worst health status, even as compared to other American Indian populations. On the next slide, you can see another map that shows concentration of American Indian population by state. And there are 7 states that have more than 3% American Indian population. In South Dakota, it's about 11%, where I'm from originally. And here in North Dakota, where I work currently, it's about 6% of the population is American Indian. One of our big challenges from a policy and advocacy perspective is that we have federally recognized tribes in 35 states. So therefore, we have 15 states and 30% of the Senate that does not have tribes in their constituencies. So that puts us at a significant disadvantage politically because senators and representatives from states that do not have tribes typically don't care about our issues because addressing our issues won't help them personally to get reelected. So we've had a real challenge in terms of political advocacy. And this is one area where I think we could work with NACCHO and other organizations to become stronger partners in advocacy. Next slide. When we look at American Indian health disparities, American Indians die from significantly higher rates from preventable causes. Things like diabetes, nationally, it's 208% greater death rate. Alcoholism, 526% greater rate of death. Accidents and unintentional injuries, 150% greater. And unfortunately, suicide is 60% greater. As a side note, it's also important to acknowledge that nationally and in every data set we have, although American Indians do have higher rates of problem drinking, we also have the highest percentage of abstainers from alcohol. So depending on the data set and how you want to interpret it, we could say American Indians have the largest problem with alcoholism, but we could also look at the same data set and come to the conclusion that American Indians are the most sober population in the nation as well. So we tend to have less social drinkers, many more abstainers, but unfortunately we do have some segments of our population that has challenges with alcohol addiction. The next slide, this is looking at some disparities in the state of North Dakota. And this is from the North Dakota Department of Health. The average age at death in North Dakota for the white population is 77.4 years, and for American Indians, 56.6 years. So this really is third world health conditions that we're dealing with. And one of the things that I tell my public health colleagues and academics is that you do not have to cross an ocean to find third world health conditions. It's in our inner cities, it's in our reservation communities, and in other communities where we have terrible disparities on the order of third world health conditions. So from my perspective, this really is a public health crisis, just screaming for intervention, but we have yet to make adequate improvements to reverse the decades-long challenges that have led to these disparities. On the next slide, this shows us poverty rates. And for American Indians and Alaska Natives nationally, it's 2.5 times as many of our people live at or below federal poverty as compared to the white population. And those numbers are even worse in the Northern Plains, unfortunately. Very high rates of poverty. So next slide, please. So it is important, and I really appreciate the theme of this panel session to look at history and how things evolve over many decades. And when I think about Indian country, it's important to remember that this is all Indian country, every part of the United States. And historically, of course, we had many millions of people who were living here. It's estimated that there were about 20 million indigenous people in North and South America, and probably about 5 million of those were living in what is now the United States. On the next slide, if we look at 1790, the 13 colonies were not good for the northeastern tribes. Now, there are very few tribes left and very few American Indians in the Northeast. And that's not because historically we didn't like the East Coast, it's because of the 13 colonies. On the next slide, you may have heard of Amherst, Massachusetts, Amherst College, for example. That's named after Lord Jeffrey Amherst, who was a colonial governor in the late 17th century. And he was famous because he is the one who ordered the distribution of blankets from a smallpox hospital with the purpose of killing the local tribes in the Northeast. And if you Google Amherst and smallpox, you can actually see the letters that were written back and forth from Amherst ordering the local army to distribute these blankets, and that hopefully will have the outcome that they intend, which was to wipe out the tribes. And unfortunately, they were very successful at eliminating many of the tribal populations in the Northeast. So this, in many ways, is our first documented case of bioterrorism, and it's our own colonial government. Unfortunately, we don't learn much about this in our history books, unfortunately. So much of the history for American Indians is really unknown to the general population. On the next slide, you see the date 1830. There was a date set aside for relocation of tribes from the southeast to what is now Oklahoma. So in this relocation process, many of the tribes were actually split apart, where some of the population stayed at home in their home community and others moved to Oklahoma. On the next slide, this is a map showing the migration of many tribes to what is now the state of Oklahoma. So during this process, again, some people staying in their homelands and some moving to Oklahoma. That's why we have, for example, Seminoles in Florida and Seminoles in Oklahoma. We have Cherokees in North Carolina and Cherokees in Oklahoma. Choctaws in Mississippi and Choctaws in Oklahoma. So you kind of get the idea. Many of these tribes were split apart. So dispossession of land, dispossession of resources, loss of access to traditional homelands and ceremonial sites obviously had an impact on the American Indian population in the Southeast. On the next slide, the date says 1860. And after the gold rush that started in 1849, that actually wiped out many of the tribes in what is now California and Oregon. So a lot of the disparity and much of the history it's much more than just simply decades. It really is generations of history that have had a negative impact on the American Indian population. On the next slide, this shows the American Indian and Alaska Native population by county. So it's the concentration of American Indians. And you can see the vast majority of us are now in the West. There are entire states with essentially no tribes and very few American Indian individuals. So as a population, we need partnerships and advocacy. But kind of thinking about the theme of this discussion and how inequity occurs over many decades and generations, go to the next slide. I did publish a manuscript with one of my colleagues here at NDSU. It was published last year, actually, on the intergenerational basis for chronic disease disparities. And when we look at the patterns of loss of life of American Indians, there really was a massive genocide or an attempt at genocide for the indigenous people of this continent. There's also the concept of historical trauma, in which potentially historically adverse events can have an impact on future generations. And I'm sure many of you have heard of the concept of epigenetics. And what we're seeing through epigenetics is that stressful events can have an impact on gene expression. So we could have potentially genetic changes and variants passed on from one generation to the next based on significant stressful and cataclysmic events. The next slide shows the American Indian population decline and recovery over this time frame. And like I had mentioned, it's estimated there were over 20 million American Indians in North and South America, and what is now the US, about 5 million. By 1900, there were only 200,000 American Indians left. So it was a near complete genocide. But what we've seen in recent years is really a resurgence of our population. In the 2010 census, there were 5 million self-identified American Indians, both American Indian alone and American Indian and other race or ethnicity. Next slide, please. So the other thing to consider that is unique to American Indians is the boarding school experiences. We had many numbers of our people taken away to boarding schools and had significant exposure to abuse and neglect, and not surprisingly bad outcomes. Next slide shows the concept of historical trauma related to the boarding schools. That's a picture of a graveyard right next to one of the boarding schools in Carlisle, Pennsylvania. And every one of those headstones represents an American Indian child between age 6 and 12. And we had significant death rates within the boarding school systems. We don't know exactly why. There were outbreaks of tuberculosis, but that doesn't explain all of the death that we saw. But one of the big challenges is that the survivors of boarding school wound up witnessing so many of their friends and classmates as children die, obviously at an early age. Next slide, please. I'm sure many of you have heard of the Adverse Childhood Experiences Study. We just completed the ACE study in South Dakota. And unfortunately, the tribal populations have significantly more adverse childhood experiences than other populations. Next slide, please. In addition to that, we see adverse adulthood experiences and certainly high exposure to toxic stress based on poverty, poor nutrition, alcoholism and substance abuse, high death rates. And next slide, please. One of our big challenges is that we see this passed on from one generation to the next. And survivors of the boarding school were not taught traditional parenting skills or family structure, and children who grow up with abuse and neglect tend to become parents who abuse and neglect. So we see it going on from one generation to the next. Next slide, please. So this is just a brief summary. Huge and significant challenges in terms of social determinants of health related to poverty, unresolved trauma, inattention and neglect, racism still toward American Indians, particularly in the Northern Plains. And then in terms of addressing things from a perspective of equity, quite often American Indians are ignored. We do have a lot of inattention and neglect of our issues. So next slide, please. Looking at inattention and neglect, and I think about our organizations that we have here, for example, NACCHO, and there's also ASTHO. So who's missing in that equation? So when we look at associations for cities and counties, that's wonderful. Associations for states and territories, again, we need this. Where do the tribes fit in? Unfortunately, the tribes have largely been left out of some of these larger discussions at the national level just by how we're structured. And I know that people within NACCHO and ASTHO are very connected to and dedicated to promoting equity. So maybe that's part of our future discussions is how do we include tribes in these organizations and these discussions? Next slide. And just some good news, our Master Public Health program here at North Dakota State, we do have an American Indian specialization. And I'm very happy to report that of our first 5 cohorts of students, we've now matriculated or graduated 25 American Indians in the Master of Public Health program. Next slide, please. And again, coming back to our traditional stories and our traditional thoughts and beliefs, this is a quote from Chief Sitting Bull, who is a Lakota leader from many years ago. He said, "Let us put our minds together and see what life we can make for our children. Let us put our minds together and see what life we can make for our children." And that is thinking about future generations. That is thinking about resolving the intergenerational and the cross-decades issues related to health inequity. And from my perspective, public health is consistent with traditional Lakota medicine. And my hope for the future is that all of us find ways to work more closely in partnership around the whole idea of promoting equity to be inclusive of American Indians. And next slide. And that's my contact information. Again, I apologize I couldn't be there in person, but in the interest of time, I'll go ahead and end it there. Thank you very much.
Thank you so much for joining us. Okay, so now it is my pleasure to introduce Dr. Linda Rudolph. She is the director of the Climate Change and Public Health Project in PHI's Center for Climate Change and Public Health. She is also the principal investigator on a PHI project to advance the integration of health in all policies in local jurisdictions around California. Previously, Dr. Rudolph served as the deputy director of the California Department of Public Health's Center for Chronic Disease Prevention and Public Health, and the health officer and public health director for the city of Berkeley, California. While at CDPH, Dr. Rudolph chaired the Strategic Growth Council Health in All Policies Task Force and the California Climate Action Team Public Health Work Group. Dr. Rudolph has also been the chief medical officer for the Medi-Cal Managed Care, medical director for the California Division of Workers' Compensation, executive medical director for the Industrial Medical Council, staff physician in the CDPH Occupational Health Program, and, if that's not enough, a physician for the Oil, Chemical, and Atomic Workers International Union. Please welcome to the podium, Dr. Rudolph.
Good afternoon. In the last moments of this very thought-provoking and inspiring conference, I want to ask you to think about something crucial that's been missing from our conversation in the last few days, and that's the relationship between healthy people, healthy places, and a healthy planet. Let's start with coal. Every step in coal's life cycle is an assault on human health, from mining to transport to waste. Coal combustion releases a toxic brew of pollution. The burning of coal, oil, and gas for energy is the largest single source of carbon dioxide. Carbon dioxide and other greenhouse gas emissions are causing climate change. Global temperature rise, changes in the world's water cycle, sea level rise, global melting, and ocean acidification. Coal-fired power plants lead the pack in carbon dioxide emissions. Over 50% of the 4 million people who live within 3 miles of the worst polluting coal plants are people of color. To compensate for falling coal use in the US export of coal has increased rapidly, largely to Asia, where power plant emissions are a leading cause of air pollution, estimated to kill about 4,400 people each day in China. I want to go backwards. A few months ago, I visited Bataan in the Philippines, where dust from open coal import and storage facilities causes severe asthma in children and threatens the livelihoods of fishermen. Half of all Americans live in counties with unhealthy air. 4 of the most polluted counties in the nation are in California's Central Valley, where nearly half the population is Hispanic, 1 in 6 children have asthma, and 1 in 4 live in poverty. In the San Joaquin Valley, the major sources of pollution are diesel exhaust from trucks and agricultural machinery and motor vehicle pollution. Pollution levels are highest near busy roadways in areas populated largely by people of color with low incomes. Our transportation system also fosters sedentary lifestyles associated with diabetes and heart disease, also epidemic in the San Joaquin Valley. And while affordable and reliable transportation is essential for access to jobs, schools, and health care, transportation spending shortchanges the bus systems and safe walking and biking infrastructure that people of color rely on most heavily. Transportation is the second largest source of greenhouse gas emissions and carbon dioxide in the US. The other key source of air pollution in the San Joaquin Valley is livestock waste that produces not only smog-forming volatile organics, but also has caused widespread water contamination in the valley and antibiotic resistance across the US. Livestock is also a major source of methane, a short-lived climate superpollutant with 22 times the global warming potential of carbon dioxide. The health and environmental problems of the people in the San Joaquin Valley are all being seriously exacerbated by climate change right now. In the last 5 years, we've had 4 of the hottest years ever recorded. NASA just reported that 2016 is blowing away prior heat records. Many densely populated low-income communities are park and tree poor with lots of pavement, creating dangerous heat islands. Climate change is on track to cause temperatures in some regions of the world that exceed the human body's physiological capacity to adapt, with huge implications for the world economy, agriculture, and human health. Rising temperatures cause increased ozone levels and smog. Coupled with the drought, which is also increasing in frequency and intensity due to climate change, heat increases the risk of wildfire and dries out soils, creating dust that carries the spores of valley fever, now epidemic in the San Joaquin Valley. Much of California remains in an exceptional drought, the worst in its history. Hundreds of thousands of acres were fallowed in 2015, leading to increased food prices, knock-on food insecurity, and in turn associated with higher rates of hypertension and diabetes, and tens of thousands of lost jobs, primarily low-wage agricultural jobs. The wells providing drinking water to thousands of people in the Central Valley have literally run dry, requiring Tulare County to establish bottled water distribution systems and community showers. The prolonged drought of the Dust Bowl forced 2.5 million people to leave the Plains states. In 1935, Collier's magazine had an article in which they reported about a migrant's welcome. California's relief rolls are overcrowded now, said the welcomer. No use to come farther. There really is nothing for you here, nothing. From 2007 to 2010, Syria experienced severe drought, leading to crop failure and an internal migration of about 1.5 million people that security experts believe was a precipitating factor in the civil war and subsequent influx of refugees to neighboring nations and Europe. Many places are experiencing climate change not through drought, but through increasing frequency and intensity of extreme storms and flooding. Hurricane Katrina displaced more than 1 million people. Many of those evacuees went to Houston. There, local residents were unhappy about the arrival of mostly poor and black people from New Orleans, and they complained that they were causing a crime wave, an accusation which was later disproven. Nearly 45% of displaced black New Orleans residents had not returned a year later, primarily because of the lack of affordable rental housing and the slow pace at which that rental housing was rebuilt. In May, Houston suffered record flooding. Coastal communities are at risk of flooding and inundation from sea level rise, which could force 13 million people in the US from their homes by the end of this century. Native Americans in Louisiana are the first official US climate refugees, but Alaska natives are also losing their ancestral homes as the permafrost melts and Miami Beach floods with each king tide. If we continue business as usual, land degradation, desertification, sea level rise, and extreme weather events may displace hundreds of millions of people globally. How many walls will we try to build then? Fortunately, things are changing. The world's 197 nations agreed in Paris last December that we must act now to limit global warming to below 2 degrees centigrade. But climate justice advocates led by the world's most vulnerable nations, who have contributed very little to cumulative greenhouse gas levels, pushed hard for a 1.5 degree centigrade target. What difference will a 0.5 degree of warming make by 2100? A doubling in the number of water shortages in Mediterranean regions, 50% reductions in staple crop yields in Central America and West Africa, 10 more centimeters of sea level rise, which will threaten the viability of many of the world's largest cities, like Bangkok, severe degradation of the coral reefs that serve as the livelihood for over 500 million people. The foreign minister of the Marshall Islands said, "For us, it's 1.5 to stay alive." Meanwhile, the oil industry has taken a page from the tobacco industry, lying about the science, pitting climate action against jobs in the economy. They're spending tens of millions of dollars to derail climate legislation. They're funding front groups that run ads showing, for example, a Latina family at the gas pump complaining about the, quote, hidden gas tax. The tagline, "There goes my college education." The truth is that it's today's youth and their children who will face truly catastrophic impacts if we do not act now. The Lancet Commission on Planetary Health said, "We have been mortgaging the health of future generations to realize economic and development gains in the present. By unsustainably exploiting nature's resources, human civilization has flourished, but now risks substantial health effects from the degradation of nature's life support systems in the future. To safeguard human health, we must maintain the health of the planet on which we depend." Climate change is happening now. It acts as a threat multiplier for all of our existing health challenges. It severely exacerbates local and global health inequities. It threatens our air, water, food, shelter, and security, and it's thus literally an existential threat, potentially catastrophic for human survival. But all is not bleak, although it might seem like it. We can do something about this. We have available, feasible, cost-effective climate solutions, many of which have huge health co-benefits. We can use our public health voice, values, expertise, and credibility to advance these solutions. Implementation of the Obama Clean Power Plan, now on hold due to court challenges from Republican states, would avert over 3,000 premature deaths and $29 billion in healthcare costs each year. Energy efficiency upgrades could reduce excess deaths from particulate matter by up to 55%, with the biggest impacts in the most polluted neighborhoods. Eating less red meat reduces obesity, heart disease, cancer, diabetes, antibiotic resistance, water contamination, and methane emissions. Reducing food waste reduces insecurity and methane emissions. Vehicle fuel efficiency standards reduce carbon emissions, air pollution, and gas costs for American families. Active transportation and public transit have profoundly positive health impacts through increasing physical activity while reducing greenhouse gas emissions and pollution. The California Department of Public Health found that a feasible increase in biking, walking, and transit use would reduce cardiovascular disease by 12%. That's our leading cause of death. Greening our park-poor neighborhoods would reduce heat illness, provide places for physical activity and social connection, reduce crime, and air pollution. Local health departments are beginning to address climate change. The Bay Area Regional Health Inequities, the Southern California Public Health Alliance, Seattle, Los Angeles, and others are starting to build health department climate change capacity. San Francisco and others are conducting neighborhood climate vulnerability assessments. Fresno's incorporating heat vulnerability and energy assistance in nurse home visits. Contra Costa evaluated the health co-benefits of various strategies in a county climate action plan. Tulsa is expanding vector-borne disease and mosquito surveillance because of climate's impact on mosquito habitat. Milwaukee is working with a homeless shelter to harvest rainwater for use in a community garden. Pima is addressing heat illness prevention for the homeless and those with mental illness. Salt Lake County held a public workshop at which the Utah Climate Action Network was launched. San Luis Obispo, Philadelphia, and others are integrating climate change into public health education and outreach. Columbus is partnering with faith congregations. These are exciting beginnings, but we must do much more and with much greater urgency. Carbon dioxide levels are higher now than they have been in at least the last 800,000 years, and possibly in the last several million years. We have a global carbon budget, the total amount of greenhouse gases that we can pour into the atmosphere before we're locked into dangerous temperature rise. Just 6 years of current emission levels would blow the carbon budget to stay below 1.5 degrees of warming. 1.5 to stay alive. Climate change is a public health emergency, and it demands an emergency response. When I was in the Philippines, I met Gloria Capitan, a community leader and grandmother who circulated petitions and brought legal actions to clean up the coal dust that was sickening her community. Last month, she was murdered, shot in the head. Gloria is just one of hundreds of community, environmental, and climate activists who have been murdered around the world in the last decade after finding themselves on the front lines of the battle to defend their communities, their homes, their health, and their environment from corporate or state abuse and from unsustainable exploitation. Shortly after I visited the Philippines, the Utah legislature approved $53 million at the behest of a large coal company to fund a coal export facility that would ship 9 million tons of coal a year to Asia from my hometown. The terminal would be in West Oakland, a largely African-American community with alarming rates of asthma and poverty. Local public health experts and the Alameda County Health Department joined with labor and community organizations to oppose this facility. On June 27th, the Oakland City Council voted unanimously to ban coal shipment based on local health concerns and on concerns about climate change. The council recognized that every local decision about the extraction, transport, use, and export of fossil fuels impacts our health at home and the health of people around the world. We are all in this together. House Leader Paul Ryan told the Republican convention, "Democracy is a series of choices. We must make a choice. We in public health must make a choice. We can choose to let big oil's deception go unchallenged. We can choose not to say the words climate change because the issue is politicized and we're afraid to offend. We can choose to let climate change wait because other problems appear more pressing. Yes, violence, poverty, racism, immigration, these are urgent and pressing issues, but climate change ups the ante on them all. We do have a choice. We can speak out on what climate change means for health and for equity. We can fight for the urgent and radical transformation of our energy, transportation, land use, and agriculture systems, and the race and power dynamics that shape them. We can advocate not only for social, economic, and environmental justice, but also for climate justice. We have a professional and a moral responsibility to join the global movement for healthy people, healthy places, and a healthy planet. Thank you.
Great, so thank you to all of our panelists. I'm going to turn it over to Drs. Fullilove and Dr. Rudolph for the Q&A. We're going to reset the clock for 10 minutes. You all know where the mics are. I think we have the kickball mics. We have the box? Okay, so I'm going to turn it over to the ladies. Fire your questions away. Thank you.
You know the mics are over there and over there, if you would like to ask a question. Come on, people in the front row. I know you got a question. There you go.
Hi, this question, I guess, is for both of you, and it speaks to themes that you both raised, but also themes that have been raised earlier in this conference. And that is that many of us are traveling in our own little bubbles. And so we don't know about stuff going on across town. We don't know stuff going on across the planet. You know, we just like in our own little passively undisturbed bubbles. So what strategies would you suggest for public health departments or public health workers to help people burst through those bubbles? Because in the same way, you know, the way I've been thinking about it is that people don't know that just across town there are other folks who are just as kind, funny, generous, hardworking, smart as they are, who live in very different circumstances. And if we were to burst through those bubbles by having, say, public health departments send their employees out 1/2 day a week to work in a prison or a senior center or a child care, you know, just something to get people across there, that we could at least witness our common humanity, and that might bind us together. And in the same way, we don't understand not only that people, but the different like climatic, you know, urgencies. It's a matter of urgencies. I guess that's what it is. Like, so how can we understand the urgencies of other people's life conditions if we stay in our own bubbles? And how can public health workers and departments create mechanisms for everybody to understand those urgencies?
Well, that's what I was describing about our experience in having people read Urban Alchemy and go visit their cities. Part of this issue of race and class, our American cities are divided by race and class, and we're not meant to get to know each other. and we're not meant to understand the urgencies of other people's lives. But if you go take a tour with a bunch of people and you start to get to know the other neighborhoods, and especially if you start to find the places they love and you get to know them, it opens up your heart and it opens up your imagination. In a way, what we think is that we all have blinders on, but when you start to walk your city with other people, it's like having a prism and all of a sudden you see the rainbow. It's an amazing thing how people's hearts shift. And it's that affective thing that I think allows you to feel the emergency. So when the people in Niagara Falls said, "Love lives here," that's their feelings. And love is as big as Niagara Falls. I think this is fundamental. I completely agree with you about the urgency of climate change. It's terrifying. But I don't see how we can solve the problems of climate change if we don't start talking to each other. So there's an outcome, which is we fight climate change, but there's a process, which is we have to walk our cities and get to know each other. So I see these as hand in glove. You can't, it's not that one goes before the other, one is the outcome, but the other is the process. So let's all walk our cities together. You will be astounded at how life-changing it is and how it breaks down the silos.
Yeah, I completely agree that these things aren't separate. And in fact, many of the same forces and the same systems that are causing this disjuncture and disconnectedness in our cities and the way that we live and the segregation of our cities, in fact, are the same forces that are really allowing climate change and other environmental degradation to happen. So, and it's also true that, if we really listen to the people around us, and I don't mean just in our immediate little tight circles, we'll find that there's all sorts of people who are very connected to what's going on in the rest of the world. San Francisco has a huge Filipino community. They know what's going on with Gloria Capitan and coal dust in Bataan Peninsula. So we are a nation of immigrants in every part of the country now, and if we listen to those neighbors, and instead of othering them, then I think we also start to really create the kind of understanding of what's going on around the world that will also help us fight climate change and build a process that's more functional.
Thank you for that. That was a great question, because that is really the challenge before us. How do we get to know each other? It's very urgent. I think you have a question over here.
Yes, my question may be a little bit different, so just bear with me. As we speak about regentrification, or at least the impacts as you kind of focused on the cities in both of your presentations, there's an unintended consequence that we also face. So for example, as we've seen migratory patterns change where immigrants are not just going into major cities, but they're going in the outskirts, into the suburbs, the rural enclaves. There's an impact where we find individuals who are leaving essentially for this direction of the new regentrified or redeveloped urbanized framework that has an impact on our suburban and rural locations in our rural counties and the brain drain essentially that leaves. If you make the mention of Niagara Falls, as you know, to the southwest of that is Buffalo, and how Buffalo has become depressed beyond any shape, means, and form. But I can also point you to Sullivan County, which is also clearly depressed and always ranking at the bottom of, I'm using New York as an example, the bottom of the county health rankings. And there's that degree of impact that has when you talk about the inequity that also flourishes within our other aspects of life where we live. So instead of just the cities, how do we address this imbalance that we're also seeing in all of our neighborhoods, regardless of whether or not they're in an urban setting or not?
Well, in public health, we get a lot of people get a little bit rigid about definitions. I've studied cities in France with a French urbanist, Michel Cantal-Dupart, and one time I was like, how do you define a city? Because, you got to define it. And he said, well, there's a French historian who said that a city is a place with 2 bakeries. And interpreting this very small village in France can have 2 bakeries. And I was like, one time I stayed in a little village that had 2 bakeries, and you had to make a choice. You couldn't buy bread at both. And then you picked one, and then who you waited online with and getting to know the clerks, blah, blah, blah. Did you like the bread better? In the American context, I think we can interpret this as a city as any place that has 2 religious houses of worship. I think that covers it, because you have to pick one. So we're talking about human settlement, and it doesn't have to be Los Angeles. It could be, some little small town where people live together. How do they live together? It doesn't have to be big for us to segregate it. We put a railroad track through the middle, we put a highway through the middle, and then one group lives on one side, one group lives on the other side, and we don't get to know each other. So if we just let go of the idea that urban means big, and we think of urban as meaning human settlement, I think we'll do fine. We have 1 minute and 50 seconds. Do you want to have a last?
So a quick question is, historically from the research, it seems like that public health focus has been on addressing health disparities. So using the analogy of 3 sisters that was presented today, how do we move the focus of public health? So your thoughts about that from helping the babies by helping them, with swimming or saving them, rather than walking upstream and finding the source. So in other words, how do we shift the focus from health disparities to finding health inequities and social determinants of health?
This panel is called Slow Violence, and we gave 3 examples of slow violence. I talked about slow violence in cities, and then Dr. Warne talked about slow violence against Native Americans, and Linda talked about slow violence against the climate. We have to address slow violence. That's how we change it. These are processes. So there are processes by which we do genocide, destroy communities, and destroy the planet. And that's where the action is. We have to look at the process that's destroying us.
And the powerful forces that are benefiting from that destruction. We all may be complicit in some way, but there's definitely a need for us to actually think about what the political and structural dynamics are that let this slow violence continue to be perpetuated, and join together and speak out against it and in favor of what in Native American tradition has always been doing what's best for 7 generations.
Sorry.
Can you guys turn this mic? Okay. I just had an aha. Okay. And it's related to, you started out, Dr. Fullilove, with, process and outcome and both. And I said something earlier when I was talking about definitions of health equity. Health equity, the Healthy People 2020 definition, as attainment of the highest level of health for all people, and outcome versus my definition, assurance of the conditions for optimal health for all people, a process. And I want to know more. I want each of you just to say something about this tension between process and outcome. Is there some kind of societal predisposition we have to just looking at outcomes and not processes because we're ahistorical? Or what is going on? Why are we not willing to engage in a look at process? Is it because the people who do the process try to be invisible, or what? Talk to us about that. That would be
So I'm a psychiatrist, and when I was in psychiatric residency, one of the things that they taught us was the patient is going to ask the key question as they're leaving the office.
So let's thank our panelists. Great job. Thank Dr. Warne for joining us virtually as well.